Today this is one cataract surgery which is slightly different from the routine cataract surgery because this patient had silicone oil filled in the eye cavity. So there was no plan to remove the silicone oil, and this is the appearance of the cataract, and we can appreciate that the patient has significant amount of nuclear sclerosis, and specifically there is a plaque on the posterior capsule which is commonly seen in these eyes which have silicone oil, and there is some amount of posterior synecdoche as can be seen in the superior nasal part of the iris. This is the fundus photograph, and this patient had a detachment in past for which two surgeries have been done. The buccal surgery was unsuccessful, so silicone oil was instilled and now retina is on, and patient at the end of the surgery had recovered to a vision of 6/24. Patient was highly myopic. So a corneal incision has been made and now performing anterior capsular excess. These eyes usually have some amount of emulsified oil in the anterior chamber, which is automatically drained the moment we make entry for the anterior chamber paracentesis. So even if there is some amount of emulsified oil, you don't have to do anything extra. Capsular excess is usually not an issue because there are no pathological changes whatsoever in the capsule and the behavior is absolutely normal. Creating a side port. The most unique problem in these eyes is that the oil has a tendency to prolapse up. Being in an environment where there's water and oil, so oil being lighter is always buoyant and it has a tendency to move towards the anterior chamber, and this poses a problem the moment you have an opening which can allow the access of the oil bubble into the anterior chamber. And if there is a pressure difference which is significant, then the oil can actually seep through the zonules also. So there is a nucleus which has been defined by using hydrodelineation technique, and this is not a very large nucleus which can be easily chopped. So we are using a horizontal chop technique. So this is a direct chop which saves a lot of ultrasound energy which is dissipated inside the eye. And once the pieces have been chopped into smaller segments, one can proceed to emulsify and consume them. It is always a good idea to segment the large pieces into smaller chunks, and this will prevent any injury or insult to the endothelium, because then it is possible to perform the emulsification process in the capsular bag, because smaller pieces will not prolapse out into the anterior chamber. So this is one key factor which I have emphasized in one of my videos, where I have used this technique and explained that how one can have pristine clear cornea if one is operating hard cataracts. So this is the epinucleus which is being removed. It's always good to remove the epinucleus using the Phaco handpiece because epinucleus is little bulky and Phaco handpiece has a greater flow of fluid. So it's convenient, fast and easy to remove this epinucleus through a Phaco handpiece rather than the irrigation aspiration handpiece, which is a very small port. We can appreciate the capsule, posterior capsule, which is shimmering because of the presence of oil behind it. And you will see that once exiting out of the anterior chamber, it's very important that one has to take care of leakage in the anterior chamber, and one should always seal the wound immediately before removing the irrigation or any instrument occupying the main port. And this will prevent collapse of the anterior chamber, which can cause a significant pressure difference and pull up the silicone oil. Silicone oil prolapsing into the anterior chamber is a nuisance, And once it happens, then the oil keeps on coming continuously, because once it has found a passage, the normal gravity and the kind of density the oil and water has, the oil has a natural tendency to come up. We can also appreciate this plaque, which is just not able to be peeled using a irrigation aspiration cannula. So this is usually a feature in these cataracts, and again when entering out, one has to take care that the chamber doesn't collapse immediately, and one has to replenish the viscoelastic so as to take care of the space in the anterior chamber. The plaque has a definite edge which is definable, so I decided if I can hold this plaque and peel it away if it is possible. So grabbing one of the edges of this plaque and trying to peel it out, although it's very difficult because the edge is very minute. So I am looking for places where I can grab this plaque and try to peel it away from the capsule. A clear visual access, especially in the central part, is important for managing good visual outcome in any cataract surgery case. So same goes with this. But at this moment, when holding and trying to peel it, I realized that this plaque is too tightly adhered to the posterior capsule, and any attempt to remove this plaque may cause damage to the posterior capsule, which is something which I want to avoid at any cost. So I decided to proceed with implantation of the IOL, which is a hydrophobic monofocal IOL, and later on we can take care of this plaque once the cataract surgery has healed and the haptic has been stabilized. We can use YAG laser to detach this plaque and let it wander into the vitreous cavity. That seems to be a much safer option compared to a situation where you have a compromise in the posterior capsule while you have silicone oil in the posterior segment. Every time when I am exiting, I take care that there is no sudden collapse of the anterior chamber, and I use a swab stick to seal the main wound immediately after exit of an instrument. Now when the surgery has been nearly finished, we are simply there to remove the retained viscoelastic, washing away the viscoelastic using the routine irrigation aspiration technique using a irrigation aspiration cannula. There are few considerations one has to take when calculating IOL power in these cases, which can be referred to from any standard textbook, but overall there has to be a 30% reduction in the axial length as calculated using A scan, and that will take care of that compensation which is required. Once the irrigation aspiration has been done, you again seal the anterior chamber so as to avoid collapse, and then you fill up the anterior chamber with BSS and seal the chamber properly so that there is no shallowing of the anterior chamber. The surgery has been done, and now this is the post-op day 1 photograph of the same patient, and we can appreciate, apart from rest of the findings, that the surgery has ended well. There is a plaque on the posterior capsule which is causing hazy media and poor vision. This patient was 6/60 with some amount of correction as expected, and the patient has been assured about improvement in vision once we do a YAG laser capsulotomy about 4 to 6 weeks after this surgery. Thank you.